Electrical impulses from the SA node spread throughout both atria. The atrioventricular node, or AV node, located on the other side of the right atrium, near the AV valve. The AV node serves as electrical gateway to the ventricles. It delays the passage of electrical impulses to the ventricles. This delay is to ensure that the atria have ejected all the blood into the ventricles before the ventricles contract. The AV node receives signals from the SA node and passes them onto the atrioventricular bundle, AV bundle, or bundle of His. This bundle is then divided into right and left bundle branches, which conduct the impulses toward the apex of the heart. The signals are then passed onto Purkinje fibers, turning upward and spreading throughout the ventricular myocardium. Electrical activities of the heart can be recorded in the form of electrocardiogram, ECG, or EKG. An ECG is a composite recording of all the action potentials produced by the nodes and the cells of the myocardium. Each wave or segment of the ECG corresponds to a certain event of the cardiac electrical cycle. When the atria are full of blood, the SA node fires, electrical signals spread throughout the atria and cause them to depolarize. This is represented by the P wave on the ECG. Atrial contraction, or atrial systole, starts about 100 milliseconds after the P wave begins. The PQ segment represents the time the signals travel from the SA node to the AV node. The QRS complex marks the firing of the AV node and represents ventricular depolarization. Q wave corresponds to depolarization of the interventricular septum. R wave is produced by depolarization of the main mass of the ventricles. S wave represents the last phase of ventricular depolarization at the base of the heart. Atrial repolarization also occurs during this time, but the signal is obscured by the large QRS complex. The ST segment reflects the plateau in the myocardial action potential. This is when the ventricles contract and pump blood. The T wave represents ventricular repolarization immediately before ventricular relaxation, or ventricular diastole. The cycle repeats itself with every heartbeat.
Okay, so you got it. So that's very elegant way of describing how the heart functions and what's the correlation with the cardiac cycle, right? Is that clear for you? So that's where the SA node is, where the AV node is, where the conduction system is, right? Now we'll go to basics of ECG. So objectives of these tutorials are, first need to understand what is an ECG, overview of performing ECG on a patient, simple physiology, and then we'll come to it in the ECG. By the end of this tutorial, all of you should be able to understand definitions of ECG, perform ECG on a patient, including explaining to the patient what is involved in ECG, draw a diagram of the conduction pathway of the heart, draw a simple label diagram of an ECG tracing, list the steps involved in interpreting an ECG tracing in an orderly way, recite the normal limits of parameters of various parts of the ECG, and then we'll go through all the different conditions which are commonly seen in cardiology setup. So basically what is ECG? ECG is tracing of the electrical activity of the heart. And it's a very simple measure which will give an idea about what's going on in the heart. Okay? Saying that, I would say normal ECG does not mean that the heart is normal. Okay? So that's an important thing you should all remember. Sometimes you get a patient of heart attack and ECG is normal, right? But then don't discard them away. You have to repeat the ECGs until you find. So you have to always see the ECG in clinical context. Okay? This is an important statement. ECG is never seen alone. ECG has to be seen in clinical context. What is the patient like? An important thing is how do you record an ECG? Now, what I do is I go down to the wards and see how the sisters are doing ECGs, right? What I found that many patients have got ECGs done without putting the electrodes in a proper place. I don't know if that's your understanding, but nobody has taught the nurses how to put the electrode, right? They keep learning from their seniors, and if the senior is wrong, then the juniors all are wrong. Okay, so I think we should all know how to do an ECG, the first thing, right? And so that you can teach your nurse where you're practicing your clinic how to do an ECG. Whenever you're doing an ECG, I think in India and our culture especially, we lack a lot of respect for others. Right? We don't respect others and others' values. We always like, come on, get the ECG done. Okay, it don't work that way. One of the reasons is we are always over stressed for the time. There's too many people to cater for. Whatever it is, when people come to my clinic, my assistants will always greet them, say hello or namaste, okay, and then we'll take them in a private consulting area, private room, which is enclosed. I'm very particular that we don't expose patients in public place or where other people are there. The reason for that is obviously is undignified to expose any woman or a man in a public place. Unless it's a medical emergency, then obviously in a medical emergency situation we wouldn't worry about that. Okay, and it's a question of life and death. But in a general setup, my private clinic, I have got a special room. It's all curtained and it's all private, so people feel happy about it. Okay, so you greet them, you develop a rapport with them. You tell them that we're going to do your ECG. You need to undress for that. Well, these are simple steps. Most of the people forget about it. So you tell them that we're going to do an ECG. What does it involve? We're just going to put the clips. You need to relax. Okay? The simple statements are very useful. So you need to introduce yourself. Many times you'll find that in our setups here, you don't use any apron. There's no name plate or name badge written on it. Okay, so you do not know a woman is exposing, whether that man, whether he's a nurse, doctor, or some ward boy. You don't know. So imagine yourself in that situation, how you will feel. Okay. So in our clinic, we tell them that firstly we introduce ourselves. My name is Dr. Sawant. I'm going to do your ECG. Okay. For that you need to get undressed. This is the place where you can hang your clothes. So we made a place where they can hang their clothes. Okay. It's very dirty to keep your clothes like that and dump it on the side of somewhere. No? So you all are doing private practice. So whenever you're setting up your setup, think about these things. This is not about medicine, this is about common sense, right? And when you're setting up a new clinic or when you've got a clinic, I think you should just take care of these things. Okay? So identify yourself or tell your staff member to identify themselves, who they are, right? I'm a nurse, I'm a nurse practitioner, or whatever their role is, and then they're going to do explain the procedure. Explain the procedure that we're going to put the clips on, and then some electrodes will be placed on the chest, and we're going to do your ECG. Okay? And permission. Obviously, when they agree to come in, it's a verbal consent. Okay? You don't need a written consent for ECG. Lay the patient down, expose the chest, wrist, and ankles. Take out all the metal stuff because it gives a lot of vibration. So you have to keep doing repeat ECGs with a lot of vibration, right? So you ask the patients to expose the chest, take out all the metal stuff, remove the socks. You need to make sure that the electrode sites are clean, right? If there are a lot of hairy sites, it becomes difficult. Okay? And you get a lot of vibratory signals, and then when there are a lot of vibrations, for doctor or cardiologist, it's very difficult to read an ECG. Okay? Normal ECG may look like a VT or atrial fibrillation. Your treatment is going to be wrong. So make sure that there are no vibrations there and ECG is clean. You may need to shave the chest. If somebody is very hairy on the chest, you may need to shave the areas where you're going to stick your electrodes. Right? We people here use the balls, rubber balls, because they're cheaper and electrodes are expensive. Each electrode costs something like 3 to 5 rupees. So people try to save money, but that's fine. To clean electrode sites, apply electrodes, attach wires correctly. Another thing I noted is because the nurse doesn't know how to do ECG or the doctor doesn't know, they attach the wires wrongly. Okay, so that's not right. You have to attach the wires correct. There is a universal code. Unfortunately, in India, all the machine companies are not following that code. Okay, I practiced in UK for a long time. In UK, all the machines are same in terms of codes. So right will be always red, right? If you have an ECG machine, red is something else, right? I have a G machine. The upper arms ones are white and black. Okay, that should not be the case. So it should have a universal code. I'm sure over a period of time it will get better. So attach the wires correctly, and then turn on the machine and calibrate the machine at 10 millimeters per millivolt, rate at 25 millimeters per second. Okay. So this is calibrated normally, that it is 10 millimeters per millivolt, and rate is at 25 millimeters per second. So that's the standard calibration. As a cardiologist, we may increase or decrease these speeds, but most of the times we don't need to do anything to this calibration. Okay. 10 millimeters is a millivolt per millivolt. And rate is at 25 millimeters per second. Record and print the ECG. Okay. So you don't take a photograph of it. ECG is an important document. It's an important legal document. So you have to record an ECG, print it, and place it properly. Okay. Why it's important legal document? You know by now why it's important legal document. Whenever you record an ECG, label the tracing. Always name, date of birth. Most of the people in India do not know date of birth still. Those who are born new and after 1980s, 90s, they know their date of birth. The old people, they don't know date of birth. So people end up writing 65 female or whatever like that. But write the name, write the full name if possible. Hospital number. Again, you have to have an identification number. Date and time. You always have to date and time the ECG. ECG has no meaning if there is no date and time. Right? If I am given an ECG which has not name and date and time, then it's useless. Right? Basic things, right? And you will see how many ECGs you will find that there is no date and time. People also, I noted that many physicians here have got some form of a cardboard on which they stick the ECG, right? And on the back of that, they write date and time. Is that good? No, you may have stuck it on a wrong patient's board, right? Then it is useless. What you need to do is write on the ECG itself, date and time, so that that cannot be changed at all. Okay, so write on the ECG, name, date, time, and reason for recording. That's very important. You have a patient whose ECG is done for chest pain, that has meaning. If you have a patient's ECG done for collapse, that has a different meaning. If somebody has palpitations, that has different meaning. And what happens is the person who gives will understand that why the ECG has been done. Sometimes you will do routine ECG. The patient wants, I have not done ECG for the last 6 months, I want to do ECG, and then that is a routine ECG, right? So label the tracing, record the ECG, record everything there, disconnect if adequate, and remove electrode. So now once the ECG recording is done, your nurse should show it to you, or you should see it yourself. See if you are happy with the ECG tracing. If you are not happy, repeat the ECG, right? Good machines, always I would recommend buy a good machine. Good machine means a standard companies in the world. You've got small companies in the world and you've got large corporations in the world. Always buy from good, large corporations. Reason being, I met some doctors who bought some machines which are not from a standard companies, and I found that the ECG will come with the automatic interpretation, right? And that interpretation is wrong if your company is a small company. Why? Because that company hasn't got a data and they haven't got skills and abilities to interpret that ECG. What happens then? You do an ECG, it comes with a acute inferior wall myocardial infarction, but actually there's no inferior wall myocardial infarction. And then you are worried because you're not an expert. You're worried that whether there is a really myocardial infarction, you call 10 people to find out. So important thing is whenever you are investing your money, there may be a difference of only 5,000-10,000 rupees, right? Why do you want to save 5,000-10,000 rupees and create a headache? So buy a standard company like Siemens, GE, Philips, all these big companies. They're the masters and world leaders in medical technology. whichever, just make sure that the company is standard. Okay, electrode placement. So there are 10 electrodes in total are placed on the patient, and it's a 12 lead ECG, right? So again, there are machines with 3 channels, right? So you should have a 12 lead ECG, complete 12 lead ECG. There's no point having a half ECG, right? Some machines do that. I wouldn't recommend that. I would suggest that you buy a machine which gives 12 lead ECG. Okay, I think average cost of a reasonable machine is 50,000, 55,000, okay, including GST. So you have 10 electrodes in total are placed on the patient, and you get 12 lead ECG. Firstly, cell-palliative dots are attached to the patient. These have single electrical contacts on them. Okay? 10 leads on the ECG machine are then clipped into the contacts of the dots. So this is an important diagram I think everybody should remember, and that's where I found the mistake. Okay? Most of the mistakes are done here. So people connect red to the left, or right to the left, right? And left to the right. That's the commonest mistake done by a nurse or a doctor. And then they are given us an ECG, and there's a way we can find out whether there's a wrong connection or not. We'll come to that when we are interpreting the ECG. Okay? So commonest mistake is right connected to the left, left connected to the right. Okay? Look at these positions. There are 6 are chest electrodes called V1 to V6, which are shown there. Right? So those electrodes are placed. We'll come to where they are placed. There are 4 limb electrodes, right arm, which is on right side. That's why I said red is right. Why universal code is red is right. Okay. Left arm is always yellow. Okay. But in India, you have to check which machine, etc., and then you have to make sure that this coding is not followed here. So right arm red, left arm yellow, left leg is green. Always left leg is green on the standard machines, and right leg is black. Okay? I think they make some mnemonics. If you want to remember that, that's fine. But what I do here is I will personally check what is written on that. Okay? It's written there, right? Right leg, left leg. So check that. Remember, the right leg electrode is a neutral one or dummy one. Okay? That's like another thing, the dummy electrode. It doesn't actually generate anything. Now coming to the chest electrodes. Chest electrodes, again, this is the commonest area where I found the mistakes done by nursing staff. What they are doing is they do not know where to put V1. Somebody just told them put it here somewhere, and they're just putting. Happening is, as a result of that, the ECGs are coming with a lot of abnormality. You're not very sure about whether there's a myocardial infarction or no myocardial infarction. There's WPW syndrome or no WPW syndrome. There's Brugada syndrome or no Brugada syndrome. Because these chest electrodes are not placed in the right place. Or one nurse does an ECG and next nurse does an ECG. So first nurse ECG electrodes are placed in a different place, and second nurse ECGs are placed in a different place. Then you don't know whether the myocardial infarction has progressed or not. And this is a common thing I have noted here. So V1 is located in the right fourth intercostal space parasternally. Okay. V2 is located in the left fourth intercostal space parasternally. And how do you identify fourth parasternal space? Any idea? Sorry? Yeah, how do you count ribs? From? Clavicle? Where do you count the ribs from? Any idea? Manubrium sterni, yeah? So, manubrium sterni. What is there at the manubrium sterni? Second rib, yeah. And what? Angle of? Louis. Yeah? The most prominent space here is angle of Louis, or manubrium sterni. Second intercostal space connects there. So, from there you are going to count down. This is where the second intercostal space is, right? This is second intercostal space, third intercostal space, and fourth intercostal. Okay? Got that? So, where the manubrium connects, there is the second rib connect. And just below that is the second intercostal space. So, So that's where we're going to. So this is where the manubrium sternum connects with the second rib. And this is the second intercostal space, third intercostal space, fourth intercostal. The fourth intercostal space just by the sternum is V1. Okay, same place on the left side is V2. Okay, and then V4 and V3. How do you connect that? V4 is located in the mid clavicular line. And which intercostal space? Huh? Yeah, fourth, fifth, sixth. Yeah, which one is that? Huh? You're saying sixth. Sixth. How many for sixth? So how many of you say sixth? Raise your hands. Huh? So now you change your mind. You say fifth. So don't change your mind all the time, okay? It's a fixed thing. Huh? So actually it's a fifth intercostal space. Okay? So there we go. So this is in the fifth intercostal space in the mid-clavicular line. Okay, so there's no ambiguity about it. If somebody is a big guy, like a fat woman with a lot of heavy breast tissue, then you might find difficult, but you try to, get an idea where the mid-clavicular line is and where the fifth intercostal space is. And the V3 lies between V2 and V4. So V3 doesn't have any specific intercostal space. It's just between V4 and V2. So if it is between fourth and fifth, then it is somewhere in between, V3. And then V5 and V6, where is the V5, V6 position? Anterior axillary line. So that is V5, right? V5 is anterior axillary line. V6, mid axillary line. Which intercostal space? What is same? Fifth. Very good. So now we're very clear. So we are in the fifth intercostal space for V4, V5, V6. And that's mid-clavicular line, anterior clavicular line, anterior axillary line and mid-axillary line. Okay? And these ones can go here, right side, left side, right leg, left leg. Okay? Again, nipple position can vary. You can have multiple nipples too. Right? Have you seen somebody with multiple nipples? No? Yeah? So there's a mammary line and you may get patient with 4 or 5 nipples. So nipple is not a landmark. So your landmark is fifth intercostal space and mid-clavicular line. So we always use bony landmark. Somebody may have mastectomy done. The breast is not there. Then how do you decide which nipple? Where is the nipple? So nipple is not a landmark. So we use always the bony landmark. Right? The nipple is located there, but that cannot be used as a landmark. You're right. Sorry? Now, yes, so there are other leads which people can do. We can continue going backwards. V7, V8, V9, just continue wrapping backwards. Personally, I don't see much reason, like in the last so many years, 10, 15 years, I'm practicing cardiology. Personally, I don't have to even do this of academic interest. Right? How many of you have done ECG with V7, V8, V9? It's not required. I'll tell you the reason when we're interpreting ECG. Because you can find the same information by looking at the front side. Okay? And that's why I'm not using V7, V8, V9. And it's also cumbersome. You're not going to make the patient lie in an odd position, and then you're not going to get an ECG. You have to put an electrode. It's all going to be cumbersome, right? You don't have time for all that. So I'll tell you how to get an information, same information, using the same leads. Okay? So this is what we learned already. V1, fourth intercostal space, right sternal edge. V2, fourth intercostal space, left sternal edge. Angle of Louis. Yeah? Okay. Fifth intercostal space. All we are discussed already. So now another thing is every company has got some variation in software and technology and buttons they make. And everybody wants to make it friendly to the doctor and the patient. Okay? So machines are different, so there's no reason to think that you are an expert in every machine. If you are new to the hospital or new clinic we go, ask the nurse there who is doing ECG every day. So she will have better knowledge of that machine than you would have. Every machine is different, and ask one of the staff on the ward if it's a machine that you are unfamiliar with. Okay? So if your machine is there, you should be completely familiar with the machine. Ask the patient to relax completely. Patients are tense. Many times patients are tense because there's AC going on. Patient is anxious whether they're going to get anything like a heart attack on the ECG. So tell them to relax, and then only you can get a good ECG recording. Any skeletal muscle activity will be picked up as an interference, and then interference will show as a P waves, and you will be finding it difficult to see whether it's a atrial fibrillation or flutter. So ask them to relax. If the trace obtained is no good, check that all dots are stuck down properly and they have a tendency to fall off. Many times the balls which we use, rubber balls on the chest, they tend to fall off. And you're doing an ECG and few balls have fallen down, and so your ECG does not get V2, V3, V4 recording. So make sure that before you press the button, all the electrodes are stuck down properly, the chest balls are properly in place. Especially the hairy chest, it becomes difficult. Is that clear how to do an ECG? Okay. Any questions you want to ask? Right side electrodes, right side ECG. Okay, so I went to Down. I go to Down and Bharati on Mondays. So we were doing an echocardiogram on a lady, and she was a 65-year-old lady, and my assistant was doing echocardiogram on her, and we're trying to figure out where the heart is. Okay, and what I do is I don't do echo without seeing ECG. Many times, many doctors will send a patient for echo without doing ECG. Have you come across this situation? There's no ECG done and they want an echocardiogram. Don't do that. First do ECG, then send patient for echocardiogram. And whenever patient comes for echocardiogram, I'll always want to see the ECG. I don't do echocardiogram without doing ECG. If there's no ECG done, I'll get the ECG done and then do echo. So this old lady was trying to find the heart, and my assistant was saying, I can't find the heart where it is. And I said, I've seen the ECG. Patient's ECG shows the right bundle branch block. Okay? So patient's ECG shows right bundle branch block, and there's nothing else. Good R wave, we do all across like a normal ECG. Okay? And the patient's name is written on the, I always check, name is written, same patient, ask the patient what is your name. Yeah, same. And then we can't find the heart. After 5 minutes of screening, there's little heart scene. That woman says, don't look on left side, my heart is on the right side. Okay, just happened last week. And then he said, Aji, आतापर्यंत का सांगितलं नाही तुम्ही? Why didn't you tell us until now? That nobody asked me. Yeah, we didn't ask. We just started like a routine echo. She said, I have got a dextrocardia. She was a village lady from a peripheral area. But she knew that every time nobody finds the heart on the left side. She was trying to check us. Where did I go wrong? I went wrong on a ECG. Okay, and why did I go wrong? Because nobody has labeled ECG properly. If her heart is on the right side, the ECG cannot be normal on the left side. Right? So some doctor or some nurse has done ECG in opposite way. So what she has done, she has put the electrodes on the right side. Okay? So she has, instead of putting these leads in the given position, what she must have done, or doctor must have done, he has reversed all this. So he has put V1 here, V2 here, V3, V4, V5, V6. However, he did not document. The cardiologist looking at the ECG will immediately pick up on the ECG that there is no R wave seen, so there is some problem in the heart, and everything will be reversed. So I did not pick it up because there is no recording that is a right-sided chest. Why I told you this story is you asked, how do you do right-sided chest? Right, so how do you do right-sided chest leads? The same thing, you just reverse it. Right? Now, only important thing in this is V4R. Okay, only one electrode you have to remember. I don't want to do everything. Only important electrode is V4R. So if you put this V4 in the right-sided position, and if you see ST elevation there, it is suggestive of RV infarct. Okay? Suggestive of RV infarct. If you have got a V4 in here. Okay, but you want to check for RV infarct, you put the V4 on this side. Do I ever do that? I don't ever have to do that because I got a cath lab. Right? So I don't care whether the RV infarct or not. Clinically, in the old times when I was a MD student, we would do that for academic interest. Yeah, we did a V4R and there's the ST elevation, and then that's How important is that? That's because if you got RV infarct, you get shock JVP syndrome. Have you heard of shock JVP syndrome? Shock JVP means patients with RV infarct are cardiogenic shock, and they have got a raised JVP in cardiac failure. And that's what the significance of this ECG lead was. If you put the ECG lead in right intercostal space, it's very complex. Okay, so that's why at your general practitioner level, you don't need all this information. Right? You ask me a question, so I give you an answer. But to be honest with you, you don't need all this information. Too much knowledge, no use. Little knowledge of everyday significance is of lot of use. That's my understanding. I don't want to know too many reactions, chemical reactions. I want to know what can I do with my patient. Is that what I need? Okay. So too much information is there. If you want to remember, remember. If you don't want to remember, let it go. Okay. The important thing is the basics. Okay. And for complex things, we are there. Otherwise, we'll lose our job. Okay. So we've done this ECG pacemaker site atrial node. You saw that on the video, right? SA node is located in the right atrium at the upper corner where the SVC IVC junction. Impulse travels across the atria. Actually, it's SVC junction. Sorry, not IVC junction. Impulse travels across the atria. It reaches the AV node. You saw that on the video. It reaches the AV node. There is a nodal delay, and then transmitted along the interventricular septum in the bundle of His. This bundle splits into two right and left branches. Yeah, you saw that on video. Purkinje fibers, and then the impulse goes backwards towards the base of the heart. Right? So this is the diagram. SA node where the SVC opens into the right atrium. This is the IVC opening into the right atrium. So SA node is just located at the near the opening of this. So it's not a structure, it's a very fine, thin, plate-like thing. If I open the heart and try to feel it, you may not feel much. It's not like a structure. It's like a thin plate of special tissue. Okay, so here is the SA node, then here is the AV node, this is a bundle of His, Purkinje, sorry, this is a bundle of His, and then Purkinje fibers. Okay. So we discussed this. ECG works by picking up the signals from the heart. Voltage is sensed by measuring current change across two electrodes, a positive electrode and a negative electrode. If the electrical impulse travels towards the positive electrode, this results in a positive deflection. If the impulse travels away from the positive electrode, this results in a negative deflection. Okay? The electrical impulse travels towards the positive. Now we've complicated part of it. Okay? Not very interested, right? Okay, for understanding purposes, you just have to have some idea. You don't have to remember this. You will see that what are these electrodes, which is positive, which is negative. You don't have to remember any of this. We'll just go through it as a part of exercise. So how the electrodes are placed is like this actually. Okay, so this is the one. If you look here, if the impulse is traveling in this direction, you will get a positive wave. And here, if this was the same impulse, you're going to get a negative wave. Right? Here you're going to get little positive. Here you're not going to get much. Okay, because it's in a 90-degree angle to this. The wave is transmitted this way. Here you're going to get nothing. Here you're going to get a little waves. Here you're going to get positive wave. Here you're going to get negative. The same impulse you will see from a different angle. So if you look at the heart and all the electrodes, basically imagine electrodes are the cameras. Okay, electrodes are nothing but the cameras, and you are looking at the heart from different angles. Okay, and these cameras are not a video camera; they are electrical cameras. Okay, so they don't take a video image; they take an electrical image, and that's how simple it is. Okay, now the electricity goes towards you, you're going to get a positive. If your electricity goes away from you, you're going to get a negative wave. Very simple. Okay, that's what this diagram means. So, what types of leads we have? You have, on reading the ECG, you have the chest leads, right? V1 to V6. And then you have bipolar leads, 1, 2, 3, and AVL, AVR, AVF. You're only collecting 10 leads, but you're going to get unipolar, bipolar, and chest leads on the interpretation. Okay? So if you look at the electrodes around the heart, I told you this. How do you look at the heart? Okay, you've got a heart sitting in the center, and you're looking at it from different angles. How do you look at it from different angles? Okay? So I'll tell you this in a simple way. Okay? So what electrodes we talked about? We talked about 1, lead 2, lead 3, talked about AVR, AVL, AVM. Okay? So these are just electrodes looking at the heart from different angles. So 1 is looking from this angle, AVL is looking from this angle, 2 is looking from this angle, right? AVR is looking from this angle. Okay? So different angles, different people are looking at the heart. Right? So, different angles, people are looking at the heart from different areas. So, this is the most important diagram you want to remember. Okay? Okay? So, those of you who are very much interested in electricity, another thing I want you to remember, this is for you who want to understand what is the axis of the heart. Okay? So 0 degree, so this is a clock, okay, like a clock. Okay, forget about 1, 2, 3. See, 0 degree, 30 degree, 60 degree, 90 degree, right? 120, 180, 270, and then 360. Okay, so this is just the angles, right, like a simple circle, the angle. And then on top of that, you are in 1 AVF, AVR, AVL. Okay, so where they are placed. Got it? Okay, so don't remember AVR, AVL, remember a circle and remember the angle. Okay, starting from 0, 90, 180, 270 and 360. Right? Back to 0. So that's one thing. Now how you look at the heart is you look at the heart on this circle from different angles. Okay? So I'll come to this 1 and AVF when I calculate vectors, when we calculate axis. You've done axis, right? Left axis, right axis, right? Everything of that division of axis based on this image. This is one of the most important image you have to remember. Why I stopped here is because you have to remember that this is the image which will give you idea about the axis. Okay, anyone is interested in axis? Do you look at axis when you see ECG or you don't bother? What you do is take a WhatsApp, send it to a cardiologist and then ask him what is the axis and can I refer a patient to you, right? That's what you do because you don't have time to do that. Okay, so if you are really interested, so you can be a GP with a special interest in cardiology, right? In England, that they have a system where general practitioners are allowed or they are supposed to take a special interest. So how it works in UK is you have all the general practices. The system is all by the government of England. And GPs, for example, if you are a general practitioner and you are always interested in surgery, then you can take up one topic in surgery and practice that in your general practice. So you have a general practitioner with interest in, let's say, simple things like anal problems, surgeon. Okay, if you have a general practitioner who is interested in diabetes, but he cannot become a diabetologist because he probably hasn't got time, or he's not that clever, or he doesn't want to spend too much time in studying. So what he does is just a GP, he does a diploma in diabetes, and then manages at his level in his general practice. But he knows his limits. He won't manage myocardial infarct at GP level or DK at his level. So you can develop your own interest because then life will become more interesting. If you have got your own interest, for example, if you are interested in cardiology, you can study more about ECGs, you can study more about cardiology, you can attend cardiology, CMEs and updates, right? So you can be a GP with interest in diabetes, so you go more to diabetes conferences, attend diabetes conferences. If you are more interested in surgery, like hernia, hydrocele, boils, you can do little surgeries in your clinic. So develop your own specialty interest, right? That doesn't require money. What you need is you have to seek knowledge all the time, attend those kind of conferences, CMEs, updates, besides all the other general updates. gets your attention. Some GPs are interested in pediatrics. They are not pediatricians, but they like to work with children. So what they will do is they'll attend conferences with regards to that. They will do exams. They also have exams. So you can be a diploma in child health working as a GP. Okay, so we can also have that kind of, we may not have formal systems soon, but you can also develop that kind of interest. So if you are interested in ECG, remember this diagram. The most important diagram which will tell you about the axis. Okay, so you heard of right axis, left axis, normal axis? Right? No? You don't know how to calculate axis? We'll go through that in our next sessions. So now coming to what is lead 1 mean, what is lead 2 means, and what is lead 3 means. Okay. So how are the 12 leads on the ECG? You have got these leads, right? They are formed using only 9 electrodes and a neutral. How is that possible? Now, how is the lead 1 formed? Right? I told you that diagram where electric signal is traveling in one direction, right? So for lead 1, you have left electrode acting as a positive electrode, the right arm acting as a negative electrode. Okay, so imagine, forget about other electrodes. Imagine only lead 1. So what is happening in lead 1 is this is a positive and this is a negative. So let's say an impulse is traveling in this direction. What is it going to represent on ECG? Positive wave. Okay, very good. So I showed you that. If the impulse is traveling here, what is it going to get? Negative wave. Or rather, if it's traveling here, it's going to get a positive, and traveling in this direction, you're going to get a negative wave on ECG. Okay. So now heart is located here, and if the ECG impulse electric signal travels this way, you're going to get a positive one. Okay. Now coming to the next one. So I showed you this picture. This is main picture. Every time you will see this picture. I showed you this, right? If the ECG signal is traveling here, it is positive lead 1. That's what you told me. Right? So very simple. Now next one is lead 2. What is lead 2? Lead 2 is nothing but a combination of 1 and, right and then left leg. Okay? Left leg is acting as a positive and right one is acting as a negative. Okay? So imagine, forget about other electrodes now, only lead 2. Lead 2, you have right one and the left leg one. And this is acting as negative and this is acting as a positive. Now imagine this is your heart located in the center and there is an electric signal traveling in this direction. How is it going to come? On the lead 2, positive. Okay? And if let's imagine the signal is traveling this direction, is it going to come as? So you got that? So that's only lead 2. That's what is represented here in that circle diagram. So the signal travels this way. This is the left ventricle here. The signal is traveling this way. Is going to see lead 2 as positive. Now see your ECG. Most of the times lead 2 is positive or negative? Positive. Right? Why is it positive? Because signal always travels this direction. Have you ever seen lead 2 as negative? Yeah, in infarction. Why does it come in negative in infarction? Because no signal traveling that direction. Right? As simple as that. If there is no electricity traveling because it's infarcted, then you will not get a positive here. You will get negative. Because the electricity may be traveling in the opposite direction. Now, which infarction will happen here? Which wall is this? Inferior wall. And what do you see in inferior wall? Which way? Where is the Q wave? In inferior wall? 2,3 AVF, right? So this is 2,3 AVF. So in lead 2, if you have infarct, you will not see a positive wave. What you will say? Negative wave. And what is that negative wave called? Q wave. Right? You just now told me. So that's the significance of this. Okay? This is about lead 2. So this is all what you are interpreting usually anyway. Now how is the lead 3? So I told you right was acting always as a negative. And left was acting as a positive and the left leg was acting as. What is in lead 3? So the lead 3 is formed using the left arm electrode and the left leg electrode. Okay? The left arm is Acting as a negative or positive now? Okay, left arm becomes, leg is always positive. Okay, I don't have that. Yeah, I don't have that one here. So left arm is going to be negative and the left leg is going to be as the positive. Written here. Okay. Okay. And then AVL, AVR, AVF are composite leads. They composite the information from the other lead. So we always ask you as a exam students or somebody asks us, so tell me where is the infarct, right? Somebody mentioned 2-3 AVF just now, right? Which wall is 2-3 AVF? Inferior. Yeah, is it written somewhere here? 2-3 AVF inferior. Okay. AVL 1 and 2 is lateral. Why did it come that way? Because of this diagram. So you just have to remember this diagram, right? This diagram. Okay? 2-3 AVF. 2 AVF and 3. Where are they located? Inferior. So this is the heart. They are located on the lower aspect. So 2-3 AVF is going to be inferior. 1 and AVL. Where are they located? Lateral. That's why it's lateral. Okay? So basis of all your ECG is going to be this diagram. If you remember this diagram, you can interpret everything. And you just have to keep thinking and it will be easy for you to interpret things. Okay? So that's inferior, lateral, right? And I told you about AVR earlier, right? You asked me about right side of the load. So I told you about AVR, right side of the heart. Where the right side of the heart comes? This image. There is the AVR. Yeah. Okay? Is that clear to you? I told you this. What is this? Leads are nothing but like a camera. Leads are looking at the heart from different directions. You're sitting here looking from down, up to down, sitting here looking down up. Okay? So imagine here just like a camera, or you're sitting and looking at the heart from different directions. So signal travels in this direction. When the signal travels in this direction, so you're going to get positive waves here, and this one is going to give you all negative. So in AVR, tell me, in AVR, are the leads positive or negative when you do ECG? Right? Have you ever seen AVR positive? No, right? So if somebody gives an ECG with AVR positive, gone wrong. Yes. Number one, you have to think that somebody might have put the leads as the wrong lead. Okay? Same with A1. So if lead 1 is usually positive. So very simple that if your lead 1 is negative, and think that is wrong with the ECG. And the commonest thing wrong is a nurse connecting it in the wrong way. Right? So AVR has to be negative and the 1 has to be positive. Whenever somebody gives a ECG, look at 1 and AVR. If they are doing wrong, then repeat the ECG and make sure that you are connecting electrodes properly. There can be other things. It's not that every time it's a wrong lead. For example, my lady with the dextrocardia who did not tell us that patient has a dextrocardia, and I look at the ECG and I told them that there's no dextrocardia on ECG, and echo technician was looking for heart on the left side. So that's the story, because the electrodes were placed properly, but they did not label properly. Okay? So these are the things you have to remember. Okay, so now coming to, I told you this, looking at the area of myocardium from different angles. So chest leads, so you know about chest leads. Okay, V1 to V2 look at the anterior of the heart and the right ventricle. V3, V4 at the anterior and septal. V5, V6 lateral and left ventricle. Okay, and that's also simple. You just look at this diagram where the electrodes are sitting, right? This diagram, this diagram. So this diagram, see where the electrodes are sitting. So they are going to sit on the front of the heart, right? And when they are sitting on the front of the heart, you are going to set the signals from the front of the heart. Very simple. Okay? If your V5, V6 are on the lateral side, so you are going to look at the lateral side of the heart, right? And I think this does not have chest leads, because chest leads are coming on the front. Okay? So you got V1, V2, look at the enter of the heart and right ventricle. Why right ventricle? No, anatomy. If you look at the heart, how is the heart? Right? The heart is a very difficult structure to understand in a three-dimension. How is the heart located? It's located like this, right? Which part of the heart is on the front? Which part of the heart? Which ventricle is on the front? Which ventricle is on the back? Right ventricle is on the back or front? Tell me how many of you say they are on front? Right on the front. Right on the front. How many of you say? 1 person, 2 person, 3. Right on the front. Okay, you can't be on both sides, okay? And rest of this, you think that left ventricle is on the front, right? Is that correct? How many of you think the left is on the front? 1, 2, 3, 4, 5. And others think both ways. Right? So, actually, right is located most of the thing on the front of the heart. Okay? Only little strip of the left ventricle. I don't have a model. Next time I'll get a model of the heart and I'll show you how the actually heart sits. Why it's important? Because your electricity is going to come from there. If you don't know which ventricle sits where, you will not be able to understand. So, right ventricle. And that's why I tell you here, V1, V2, look at the right ventricle. Because right ventricle is on the front. So, sometimes in pulmonary embolism patients, you will have ECG changes. That's the importance of this information. So, right ventricle is located on the front. You may get confused with the heart attack, but actually it's a patient of pulmonary embolism. The doctor will go and do an angiography, and on angiography you will not find anything. The patient has come with chest pain, breathlessness, saturation is low, and a not so well trained doctor thinks that this is a heart problem because ECG changes are seen, and then he goes and does coronary angiography. Everybody does angiography and finds normal coronary artery. And they leave the patient thinking that their coronaries are normal, and then the patient dies next day because the patient has a pulmonary embolism. Happens so many times where the people are diagnosed wrongly with some condition, the patient dies of some another condition. Happens with aortic dissection. I did topic with chest pain for you, right? I did explain you about aortic dissection, pulmonary embolism, myocardial infarction, right? So these things will happen. And why this information is important, right ventricle is located on the front of the heart. So if somebody has pulmonary embolism, you're going to get changes on ECG. And that's not due to heart attack. V3, V4, anterior and septal leads, V5, V6, lateral and left ventricle. Okay, so I think it's 9:13. Stop here. It's nearly an hour. So we have done the basics of ECG. Okay, we're done about the signals. I have to do so many other lectures for you. We'll gradually move on. From today's lecture, what do you want to look at? You want to know. I told you basically what the ECG means, right? I told you most important thing is about the manners you should do when you are doing a manners you should follow when you are doing an ECG. I think that's very important. We should try to improve on our cultural practices. We're very rough and tough, like the old times. That's not allowed in the new world. You have to be very gentle, genuine, honest, and kind to the patient. Try to, do all mannerisms, especially for ladies patients. Be very careful. And then I told you about electrodes, how the electrodes are placed. Okay, if you can go home or go to your clinic and teach your nurse about this. Okay, so like I did a class for you this evening. Do a 10-minute class for your nurses who does your ECG for you. It will be more perfect, and your nurses will be perfect. So that will be a very good idea. If you can go and teach them where to put these electrodes. That's a task for you. The next time I'll ask you how many of you taught your nursing staff or auxiliary staff how to do an ECG, right? And I told you how the leads are placed. I told you about how the electricity is traversed from different chambers and the electrical system of the heart. I told you how the important diagram. This was the most important diagram. You just have This important diagram in your mind, it will help you to understand the ECG. I told you about how the vectors, so this is called a vector, how the vectors travel, how the positive wave is created and how the negative wave is created, right? And here we are. Now we will be looking at individual portions of this ECG at the next lecture. Okay? Any questions from today's topic?